Good morning, everybody. And today we will discuss some of the basic points regarding approach to management of HIV in chronic liver disease patients. And first, we will discuss how epidemiology of liver diseases is changing in HIV patients, when to treat HIV, what to start, and of course, it is influenced by whether patient with HIV is having hepatitis B, C co-infections or fatty liver disease, and what are the hepatotoxicities of antiretroviral drugs, and do antiretroviral drugs per se can cause liver fibrosis. If we look at the causes of liver diseases, there are very important causes: opportunistic infections, viral infections, immune reconstitution, usual uh, risk factors like alcohol, then there are drugs, then fatty liver disease. In older studies, if we see, in both cirrhotics and non-cirrhotics with HIV, viral hepatitis and alcohol were the most common causes. About 82% hepatitis C, and more than half will be having alcohol as the cause. But if we look at the time trends, this was a review which showed that since 2000, NAFLD has been increasing as a cause of chronic liver disease, including cirrhotic and fibrosis in HIV patients, whereas the HCV has been declining, hepatitis B has been declining overall in HIV patients. So when to treat HIV? So actually liver disease does not affect the decision when HIV is treated, and ART is indicated in all individuals who are infected with HIV. This was an NEGM study, Insight Start, in which two groups were divided. One group was immediate initiation group and one was deferred initiation group. And it was shown that serious AIDS related events were more in deferred initiation group. So since that time, all the guidelines have changed that ART should be started in all individuals, irrespective of hepatitis B, C, or cirrhosis, non-cirrhosis. Everybody should be started immediately. And in this trial, 2.8% had HBV and 3.7% had HCV. In the same study, it was shown that proportion of patients developing elevated fibrosis score during the course of time was much more in the delayed groups, and also patients who had elevated fibrosis at the initial ascent had normalization of liver fibrosis much more in the immediate group as compared to the delayed group. So even in the liver disease patients, they will develop less fibrosis, and those who have fibrosis, they will experience more normalization of fibrosis when treatment is given immediately for HIV. So what to start? This is influenced by various factors: HBV, HCV, and NAFLD, and many other factors. Let's look. So if we see the prevalence of hepatitis B and C in HIV infected patients, this is a summary of studies from India, and we can see that about 2 to 30% of patients will be having hepatitis B, that is HBsAg positivity, and up to maybe around 10% will be having anti-HCV positive, and 1 to 2% will be having both positive. This was a long, big study known as NA Accord, North American AIDS Cohort Collaboration Study, and it was shown that risk of end-stage liver disease, that is ascites, SBP, bleeding, encephalopathy, and HCC. If we take HIV as the baseline, then when HCV's co-infection is there, about 7 times higher risk of end-stage liver disease events. If HBV co-infection is there, then 7.5 times. And interestingly, if HCV and HBV are both present, then the risk of end-stage liver disease during follow-up increases 17 times. So whenever we are faced with a patient who has viral hepatitis, we have HIV plus viral hepatitis, then this is the workup. This is a standard workup for HCV genotype, RNA, what DAs has he taken previously, whether there is resistance or not. For HBV, these three tests must be done: HbA1c, total HbC, and anti-HbS titers. If HbA1c is positive, then go ahead with HBV DNA. Then staging of the liver disease should be done standard method. So HIV RNA level, CD4 count, and resistance testing may or may not be needed. Assess for all comorbidities such as alcohol use, fatty liver, diabetes, and all other comorbidities should be assessed. So these are the categories drugs, and these are the 5 classes. Nucleoside reverse transcriptase inhibitors, these are the first line drugs. Emtricitabine is commonly used, lamivudine is also commonly used, abacavir is also used. Nucleotide reverse transcriptase inhibitors, tenofovir, TDF, and TAF. Non-nucleoside nucleotide reverse transcriptase inhibitors, efavirenz is the commonly used. These are not routinely used. Integrase inhibitors has become the first line agents. These are the commonly used, bictegravir and dolutegravir. And these are again entry inhibitors and protease inhibitors are well previously used, but they are not recommended as the first line agents. These drugs are available in the national, our Indian program. I will not go into the details. So what are the first line HIV agents? So these are the two combinations: nucleotide reverse transcriptase inhibitors plus nucleoside reverse transcriptase inhibitors plus integrase inhibitors, or nucleotide reverse transcriptase inhibitors plus nucleoside reverse transcriptase inhibitors plus non-nucleoside nucleotide reverse transcriptase inhibitors. These are the two categories. These are all the guidelines, which if we see all the guidelines, then integrase inhibitors plus and nucleoside or nucleotide reverse transcriptase inhibitors, all the guidelines are almost similar. This is the NACO. NACO does not recommend integrase inhibitors. It recommends NNRTI, efavirenz, instead of the integrase inhibitors. Otherwise, tenofovir plus lamivudine is similar to the all other recommendations. So if you look at how HBV plus HIV co-infection should be treated, we all know HBV should be treated irrespective of HBV DNA levels, irrespective of fibrosis levels. This is unlike the non-HIV infected patients. And ART should include TAF or TDS, that is nucleotide reverse transcriptase inhibitors, along with either of these two, emtricitabine or lamivudine. These are non-nucleotide reverse transcriptase inhibitors. And if TDF or TAF cannot be safely be used, then entecavir can be added, but it has a weak anti-HIV activity and is not a part of the HIV regime. And if none of these can be used, then PEG interferon can also be considered, rarely. Now, interesting point is that in many patients who are started on anti-HBV and HIV therapy, then HBV DNA will not be suppressed. And among the patients who have incomplete HBV DNA suppression, then on follow-up, HCC development is much more in such patients. If we see, if we take both HIV and HBV undetectable as the reference, then if HIV is detectable, risk is not much increased. If HBV is detectable but HIV undetectable, risk is almost 2 times. And if both HIV and HBV are detectable, then it is about, again, more than 2 times. And risk of incidence SCC is also dependent on what is the level of incomplete viral suppression during follow-up. If we take less than 200 as the reference point, then if the DNA levels are more than 2000, then the risk becomes almost 3 times. So it is very important that to look that DNA remains suppressed, preferably undetectable during follow-up. At least 1 hour. This time point was about 1 hour, 1 year after the start of therapy. So in such cases, when HBV DNA is not suppressible, then entecavir can be used. We can see that entecavir, after addition of entecavir, and the DNA levels declined in such patients. If we look at the treatment of HCV and HIV co-infected patients, then we know that HIV HCV co-infected patients should be treated and retreated in the same as the persons without HCV infections. But we just have to look at the interactions between HIV and HCV drugs. These are the HCV DAs which are available in India: sofosbuvir, daclofenacin, ledipasvir, and valparsvir. These are only 4 drugs that are available with us. And it is well known that HCV DAs have similar efficacy in persons with and without HIV co-infection. This is compilation of all the data on various regimes which show that excellent sustained virological response with and without HIV co-infection. These are the first line agents for HCV infection. Mostly Sofwell are nowadays used as the first line agents in all 1, 2, 3, 4, 5, and 6. This is 3. Sofwell as the first line agent in both patient without cirrhosis and compensated cirrhosis. But important to note that drug interactions are very important. Most of the drugs currently used for HIV are safe to be used with the HCV agents, except TDF, which should be avoided in patients who have eGFR of less than 60, and if ritonavir or cobicistat containing regimes are used. Otherwise, all the drugs are safe except efavirenz, which is a non-nucleoside reverse transcriptase inhibitors. It should be avoided with Sofwell, and if daclofenacin is used, then daclofenacin dose should be increased to 90 milligram per day. These or other drugs are not routinely used. Now, if there's triple infection, HIV, HCV, and HBV, what do we do? So if HIV, HCV patients are HBsAg positive, then most of the patients would obviously be having, will be on drugs which have anti-HBV activity. An important point is that we should initiate ART before DIA therapy in such patients, due to there is a risk of HBV reactivation with DIA. So at least 2 to 3 weeks of ART with HBV activity should be given before starting the DIA therapy. Now, if only anti-HBC is positive, what do we do? So most patients will be receiving ART, which will include TAF or TDF. But if ART does not include TAF, TDF, then the risk of activation is very, very low. But LFT's monitoring should be considered at end of treatment and SVR12. And HBV DNA may also be done at the end of treatment and SVR. Now, what about NAFLD? We know that whenever treatment is started, weight gain is expected in all the HIV patients who are started on ART, and most likely it is due to the return of health phenomena, because we can see that patients who have normal weight or underweight, they have much higher weight gain as compared to patients who are obese or overweight. So it is a catch-up phenomena of weight gain which occurs whenever ART is started. Now, it is also important to note that there are certain antiretroviral drug classes which have higher weight gain. For instance, integrase inhibitors have the highest weight gain as compared to the other categories. And among integrase inhibitors, bictegravir and dolutegravir, these two have highest weight gain. And among the nucleoside and nucleotide reverse transcriptase inhibitor, TAF is a drug which has highest weight gain as compared to the TDF and abacavir. This we have to remember. And this is the study we showed that whenever there is a switching from TAF to TDF to TAF, then there is a rapid weight gain irrespective of the other class of antiretroviral drugs that are used. So TAF is an agent which can cause weight gain. This we have to keep in mind. And this is some early data which they suggest that TAF regime can be associated with increased risk of cardiac events in HIV infected patients, though it is a very initial data, but this risk should also be kept in mind. But further studies are needed to confirm these findings. So these are the guidelines for weight gain and ART. So weight gain, we can see weight gain will be universal, but more with integrase inhibitors and TAF. But currently there is no recommendation to avoid integrase inhibitors of TAF due to the potential for weight gain. So further studies are needed to define these guidelines clearly. As far as the fatty liver is concerned, in HIV infected patients, there is 2 times higher risk as compared to the non-HIV infected patients. And this is a meta-analysis which showed that 35% of HIV infected patients have NAFLD based on imaging studies. And out of the patients who were biopsied, 42% had NASH and 22% had fibrosis. So these are the various factors which are related to NAFLD in HIV infected patients, and which can be drug related, immune reconstitution, co-infection related, host related, and usual risk factors like high BMI, waist circumference, diabetes, hypertension, triglycerides. These are the common risk factors which are also important in non-HIV patients, but they are also important in HIV patients. One important point is the lean NAFLD is more common in HIV infected patients as compared to the HIV infected patients. As we can see, HIV negative patients had higher BMI as compared to the HIV positive patients. Now, interestingly, 1/4 of the lean HIV positive patients has NAFLD. If there is overweight, then it increases to more than 50%. And in obese HIV infected patients, almost 3/4 will be having NAFLD. Now, on biopsy, lean, there will be having significant fibrosis in about 15% of the patients. If overweight NAFLD, 20%, and obese NAFLD, about 40%. So a significant proportion of the patient will be having significant fibrosis, that is fibrosis more than 2, 3, or 4. Whenever ART is started, we can see there is a gradual increase in the level of fat in the liver, and the proportion of patients having no fat on the liver is gradually decreasing as ART is progressing. And the level of weight gain is actually correlated with whatever is happening on the cap, that is fat is increasing. And again, TDF has been shown to be protective for weight gain, whereas we have seen that TAF is risk factors for weight gain in HIV infected patients. Now, patients who do not have fatty liver at baseline, they can also develop fatty liver during ART, and about 45% of patients who do not have steatosis at the first assessment, they develop fatty liver during follow-up on ART. And what were the risk factors? Again, we can see TAF and integrase inhibitors. These two were risk factors among the drugs which are important for development of de novo steatosis. Otherwise, there were other usual risk factors also, BMI, diabetes, etc. So this we all know that efavirenz is a has mitochondrial toxicity which can lead to NAFLD. And this was a study which showed that if we shift patients from efavirenz to integrase inhibitors, raltegravir, then during follow-up at week 48, all the fatty liver indices were decreasing in patients who had been shifted to raltegravir and who were stopped efavirenz. So, but whether this is the effect of efavirenz stopping and decreasing mitochondrial toxicity, or is there any importance? Is it due to raltegravir addition? That we don't know. Further studies are needed. So lastly, we'll go to the hepatotoxicity. These are the standard definitions for hepatotoxicity, which has been given. And patients with transaminase or bilirubin levels within the normal, these are how grading is done. And this is the patients who have transaminase or bilirubin levels who have elevated at baseline. And this is the method of grading the hepatotoxicity. It is important to note that highest hepatotoxicity will be observed in the start of initial 6 to 12 months of ART, and then after that the level of hepatotoxicity or incidence also then will stabilize. As per the current IRT regimes, newer regimes are being used, and these have actually very low hepatotoxicity as compared to the previous regimes, which are no longer used. This is the hepatic safety. Most of the drugs that are currently used, like integrase inhibitors or NRRTI, RTI, these are all have very good safety profile. These were the older drugs which are no longer used. These are the mechanisms of drug-related liver injury. I won't go into the details, but suffice it to say these were more common with the older drugs rather than the newer drugs. But we have to keep in mind differential diagnosis of ART hepatotoxicity, which include viral hepatitis, angiomatosis, tuberculosis, fungal infection, tumors, other drugs which are used. They may be on ATT, they may be on erythromycin, other drugs. And we have to keep in mind other etiologies of liver disease also that can occur in non-HIV subjects. So whenever we are faced with hepatotoxicity during ART, this is the algorithm. If there are signs of liver decompensation or grade 3-4 injury, stop. If resolved, then we should use a different regime with less hepatotoxic potential. If it is persistent, evaluate for other causes. But if the reaction type is hypersensitivity reaction or lactic acidosis is there, then we have to stop ART and substitute other type of anti-HIV agents. In case of mild injury, we can continue with monitoring of liver enzymes. There is also evidence that HIV per se can lead to liver fibrosis. These are various mechanisms that have been proposed for HIV to be leading to liver fibrosis. And this was the START RCT, which showed that about 15% of the patients will be having significant fibrosis at baseline before the start of ART. And there are many studies which have shown that HIV seropositivity per se and a low CD4 count is associated with a higher degree of liver fibrosis, whether the patient is infected with other viruses or not. So which indicate that HIV has some potential for developing liver fibrosis per se. Whether liver fibrosis can be initiated or aggravated by antiretroviral treatment, it is still controversial, but it was common in the first generation agents, which are not commonly used, but the newer agents like tenofovir, FTC are safe. NRRTIs are also safe, except one drug, nevirapine. Instis are very safe, anti-inhibitors are safe, and protease inhibitors are also safe, probably. This was the review and meta-analysis which concluded all these findings. So key take-home points are co-infections and alcohol traditionally were common causes of chronic liver disease in HIV-infected patients. NFLD is gradually increases in recent decades, and associated liver disease, the decision when HIV is treated. ART is indicated in all individuals with HIV. Liver diseases may affect how HIV is treated. If HIV-infected patient is co-infected with HBV, HCV, or has NFLD or cirrhosis, all HIV patients should be screened for HCV and HBV. For HBV co-infected HBsAg positive patients, ART should include TAF or TDF plus lamivudine or emtricitabine. If TAF or TDF cannot be used, then entecavir can be used. If entecavir still cannot be used, then peg interferon can be used. All HIV HCV co-infected patients should be treated in the same manner as HIV non-infected patients, but it is important to manage the interactions with antiretroviral drugs. If there is triple infection, it should be treated same way as HBV positive patients. There can be a risk of HBV reactivation even if there is only total HBC positive. That should be kept in mind and adequately followed. Weight gain is expected in all treatment naive patients initiating ART. Weight gain may be result of better drug efficacy, or there are off-target effects that we don't know. Integrase inhibitors and TAF have more weight gain, and whenever there is a switching from TDF to TAF-based regimes, there will be rapid weight gain. There is no recommendation to avoid these drugs for the potential for weight gain. And TAF-based regimes may be associated with increased risk of cardiac events, but this needs confirmation. Liver steatosis is twice as likely in HIV positive patients as compared to HIV negative patients. Lean NAFLD is more common. 15% of lean NAFLD have significant fibrosis, and fatty liver development or increase during ART correlates with weight gain. Patients can develop new steatosis during ART. Again, TAF and integrase inhibitors are independent predictors, and efavirenz, which is a first line NNRT, especially in India, is associated with fatty liver due to mitochondrial toxicity. This should be kept in mind. ART hepatotoxicity is very low with current generation of drugs. The highest hepatotoxicity will be observed in the first 6 to 12 months, and they should be careful. Significant fibrosis may be seen at baseline, and HIV per se and the ART drugs per se can lead to significant fibrosis in HIV infected patients. We should avoid the first generation agents in HIV patients who have risk factors for liver fibrosis or they have significant liver fibrosis. However, other drugs, newer generation of drugs are relatively safe except for nevirapine. So there I will stop. Thank you very much.